All right, let's jump right into a really fascinating and frankly pretty dangerous paradox of the human heart. We're going to talk about how cocaine can trigger a major heart emergency and, get this, why one of the go-to treatments for a heart attack can actually make the whole situation a complete disaster.
So the big question is, how on earth can a drug that's supposed to save your life end up being so dangerous? It totally sounds backward, doesn't it? Well, to get to the bottom of this, we've got to look at what's actually going on inside the body when cocaine is in the system.
And look, this isn't just some textbook theory. Let's paint a picture for you, a scenario that plays out in emergency rooms all the time. You've got a 25-year-old guy comes in with that classic crushing chest pain after using cocaine. He's having an acute coronary syndrome. The medical team has to move fast, but what they don't know is that their usual game plan, it might just have a hidden trap. Okay, so to really get why that trap exists, we have to understand what cocaine does to the body almost instantly. It's like it hotwires your nervous system, kicking your fight or flight response into insane overdrive. It creates what you could call a sympathetic storm inside your body, and your heart is right in the middle of it. The main character in this story is a chemical called norepinephrine. Just think of it as your body's own high-powered stimulant. Normally, your body releases it, uses it, and then vacuums it back up. But cocaine comes in and basically breaks the vacuum cleaner. It blocks that reuptake, so now norepinephrine just floods your system, and it can't be cleared away. This puts your body into this supercharged, prolonged state of alarm. So where does all this extra norepinephrine go? Well, it acts on two different kinds of receivers, or receptors, in your body, alpha and beta. And they kind of have opposite jobs. We're calling the alpha receptors the squeezers. Their job is to constrict blood vessels, which cranks up your blood pressure. Then you have the beta receptors. They're the racers and relaxers. They make your heart beat faster and stronger, but, and this is super important, they also help relax and open up some blood vessels. They're like a built-in safety valve.
Okay, so you've got this delicate balance between squeezing and relaxing. And this is exactly where the whole paradox comes into play. It all leads to this really dangerous situation that doctors call the unopposed alpha problem. See, the thing about cocaine is the norepinephrine it unleashes doesn't choose sides. It stimulates both the alpha and the beta receptors all at once. So your body is getting these totally mixed messages. The alpha squeezers are saying tighten up, while the beta relaxers are trying to say, hey, let's open things up a bit. It's a physiological tug of war.
And this is where it all goes wrong. Let's walk through it. Step 1. A doctor sees the sky-high heart rate and blood pressure and gives a standard beta blocker. Makes sense, right? Step 2. That drug does its job. It blocks the beta receptors, which shuts down their relaxing effect. But here's the problem. Step 3, the alpha receptors are still getting hammered with all that cocaine-fueled norepinephrine. And now they are completely unopposed. The relaxers are out of the picture. So what's the result? Step 4, you get this severe, unchecked squeezing of the blood vessels. This can literally choke off blood flow to the heart and make the heart attack way, way worse. And this is not just some fringe idea, you know? It's a major concern in the medical world. There's this quote from the Emergency Medicine Journal that really hits it home, saying that by giving a beta blocker, the effects of alpha blockade on the heart may become unopposed. It's basically spelling out this exact nightmare scenario. You try to fix one thing, but you end up letting this alpha stimulation run totally rampant. All right, so if beta blockers, which are a total workhorse for treating heart problems, are a no-go, what do you do? What's the right move for an emergency room doc faced with this crisis? Well, the evidence is pretty stark. A really important study from back in 1990 laid it all out. When they looked at coronary blood flow, cocaine by itself caused a 10% drop. Not good. But then when they added a beta blocker into the mix, wow, blood flow dropped another 15%, and coronary resistance shot up. That right there is the unopposed alpha problem staring you in the face, clear as day on the data. So, because of all this research, the playbook for treating cocaine-induced chest pain is very specific. You use things like aspirin, nitroglycerin, and calcium channel antagonists. These drugs work to open up the blood vessels without messing with the beta receptors. And, of course, if things are really bad, you go for a coronary angiography. But the big, bold, underlined rule is avoid beta blockers. It's all about not triggering that unopposed alpha agonism. Okay, so let's shift gears a bit. Let's say the patient gets through this terrifying event. What's the long-term outlook? What's the path to recovery look like? And maybe, most importantly, how do you prevent this from happening all over again?
The really great news in all of this, the key takeaway, is actually super hopeful. The prognosis can be excellent. If the person stops using cocaine, the chances of having another cardiac event go way, way down. The body is amazing and can often recover from this kind of stress, but you have to give it a chance to heal.
And that brings us to one final thought to leave you with. Understanding this whole unopposed alpha thing isn't just about this one specific scenario. It really makes you wonder, doesn't it? What other common medications out there could have hidden risks when you mix them with stimulants, whether we're talking about prescription drugs or illegal ones? It's a huge reminder that these interactions can be incredibly complex, and it really opens up a bigger conversation about just how much we still have to learn.